When your back is in pain, it's hard to ignore. It spans a healthy stretch of your body after all. Well, nurse practitioners Kayla Deters and Melissa Paholke are here from Sarah Bush Lincoln to shed some light on different types of back pain and the latest ways to treat it.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Thank you for joining us for this episode of Being Well. I'm your host, Lacey Spence, and today we are talking about something that's fine. We're talking about the back and spine. We've got two guests today coming to us from Sarah Bush. Welcome to the show, ladies.
Thank you.
Thank you.
Of course. So since you're a new guest to the show, I'll have you introduce yourselves and give us a little bit of background if you'd like to start.
Sure. So I'm Kayla Deters. I am a nurse practitioner and I work at the Sarah Bush Lincoln Benuti Clinic. And that's the clinic in Effingham, Illinois. So I'm a local. I grew up in Neoga, and I did my bachelor's through Edwardsville after doing my associate's 2-year at Lakeland College. I went to Indiana State for my master's and worked as a nurse for several years in the orthopedic floor at a local hospital. And as I continued my education, I always kind of had that passion towards orthopedics. Mm-hmm. So when the opportunity came available to work in orthopedic spine, I jumped on that. So I started with the Sarah Bush Benuti Clinic in January of 2018, and I've been there since, and I love it.
Wonderful. And then you.
Yeah, I'm Melissa Paholke, and I grew up in Newton. I also work at Benuti Clinic, just on the other side of the building from Kayla. And I have worked for Sarah Bush since 2010 in several various capacities. I got my bachelor's at Lakeview and my master's at Indiana Wesleyan and my doctorate at Northern Kentucky. And I did hospital medicine and then walk-in clinic, and then this opening came in interventional pain. And so Kayla and I kind of send patients back and forth that are having back symptoms, and it's been a really great experience.
Wonderful. So we've got two ladies here who work in close proximity with one another. And as you'll see when we start going through some of this discussion, a lot of their work overlaps as well. So today we're talking about back pain and treatment. And I feel like it's very common. I mentioned back pain, and part of our production crew was like, oh gosh, I'm struggling with that right now. So first off, how common is back pain?
So it's actually extremely common. They estimate about 85% of people will experience back pain at some point or another in their lifetime. It's also one of the most common musculoskeletal conditions that people seek primary care providers for, so very common.
Yeah, which is sad because, I mean, it literally holds our body together and, keeps us upright. So what are the common risk factors for back pain?
The most common things typically are obesity, sedentary jobs, smokers that basically can lead to deoxygenation or lack of oxygen getting to the disc. So smoking can lead to that early arthritis when the oxygen can't get to the disc. Things like a sedentary lifestyle, if I haven't mentioned that already, older age.
So the folks with desk jobs are kind of not setting themselves up for success.
Genetics also
Right.
can play a key role too. A lot of times degenerative disc disease will have a genetic component.
Now, I've heard of that, but I'm not really sure what that entails. Can you explain it a little more?
Degenerative disc disease in general. So that's just where the disc loses its hydration over time. So it can be more prone to tears, herniation, flattening. It loses the cushion in between the vertebrae.
And so that, you just said, is genetic, or can be?
Could be, yep.
Interesting. So that's one condition, but what are some other common conditions that we can experience for causing this back pain?
One of the most common is what we call mechanical or axial back pain, which is basically when you can get a strain in the back. So that's something I see commonly. Somebody moved furniture all weekend, or maybe they went and lifted something in the wrong position and they strained their back. And that typically resolves on its own. Or you have conditions like spinal stenosis, which is just a fancy word for narrowing in the spine. So it's when these nerves that run right down the central canal get narrowed or squeezed. Other things like disc herniations, arthritis. I don't know if there's anything else you want to add.
No, I think that's most of them. And I would just say that axial implies that the pain is in the back region. So we deal with axial pain, and then we deal with pain that radiates both. So.
And I'm sorry, axial and radial, what are the different causes of each?
So
Like to separate them, I guess.
they can actually have similar causes in
Okay.
certain circumstances. Radicular pain, or pain that radiates to the lower extremities, a lot of times will come from nerve compression. Axial pain, as she mentioned, could just be as simple as a strain in the back as well. There may not be nerve involvement with axial pain. It just kind of has to do with where the symptoms are located in the body.
And when you say the lower extremity, so the pain is going down into the legs, just all the way down, or does it stop, or?
So basically each of these nerves that exits on either side innervates a different area in the leg. So one of the most common nerves people talk about is the sciatic nerve. So you've heard of
Yeah.
sciatica. So that's impairment of that sciatic nerve. So each nerve follows a different area in the leg, and we call those areas its dermatome. So it's essentially the pathway it follows down the leg. So each of these nerves innervates the legs, the muscles, the sensation, things like that.
So when you're having sciatica, is that it's always being pinched, or is it in a wrong position? What's happening with that?
So a lot of times, and with sciatica, it's actually, the sciatic nerve is actually kind of a bundle of nerves that leaves the
Okay.
spine, but a lot of times it's compression of the nerve from one way or another. It could be overall narrowing. So these openings where the nerves come out on the side are prone to arthritis. So arthritic narrowing is going to leave less space for the nerves. The discs that you can see here, and actually this has a great example on Kayla's model of a herniated disc here, and you can see how it's encroaching on the nerve's space. So it can be a combination of things, but it is usually nerve involvement somehow. And I will mention too that the model that we have today is lumbar, so it's the low back, but you have the nerves of the higher up in the spine go to the arms. So you can have similar symptoms in the arms as well.
And so, do you all deal with the neck at all, either?
Yep.
Yeah.
What's the
definitely.
most common condition you see up in the neck? 'Cause I always hear like, oh, crick in the neck, or oh, I slept on it wrong, and it's just like that's the end of my youth, because I wake up with neck pain because I slept on it wrong.
So very similar things to the low back. You can have pain from arthritis, and that can come from the discs, the facet joints, which in the lumbar spine are here. You could have a disc herniation, which is causing impairment of a nerve root, which we call radiculopathy. So similar things like what you see in the low back. But you can also have in the cervical and thoracic spine, you can also have a condition where you get impingement on the spinal cord. So that's something more serious, and sometimes those symptoms present with balance issues, difficulty using your hands, so buttoning shirts, handwriting, things of that nature. Now you don't really worry about that in the low back because the spinal cord terminates at the L1 to T12 region, and then you get each individual nerve root that comes out down in this area. So a little bit different, but.
Well, and you mentioned having a serious condition. At what point should you seek physician help for back pain when it's not just a one-off bad back day? When do I need to come see one of you all?
I generally tell patients, if you're doing some conservative things at home, Aleve, ibuprofen, things like that, you're doing some stretches and you're not getting relief after several weeks to a month, or the pain becomes debilitating weakness, anything of that nature, it's probably worth seeing your primary, and they can give you prescription anti-inflammatories, steroids, muscle relaxers, formal therapy, things like that. If those things don't help, we have options like injections, which Melissa will talk about, surgery. But generally speaking, we recommend starting at the most conservative and kind of working towards the more invasive options.
Well, I'm glad you brought that up because I wanted to talk about our array of options. So besides the over-the-counter kind of methods, so are you kind of step one?
It kind of
Can
depends.
be.
Yeah.
We kind of go back and forth. Like I said, we send patients back and forth between the physician that I work with and Kayla and the surgeon that she works with. And it depends. Sometimes they end up with us first and then we send them on and vice versa. One thing adding with what Kayla mentioned, that's a trigger for me to send on to Kayla would be if the patient has a sudden loss of movement, say they have foot drop or a significant weakness. That's something where I am pretty cautious and usually will get to a surgical referral pretty quickly, as opposed to trying some of those other anti-inflammatories, those types.
Yeah, so just to kind of break down for the folks at home, what is your all's working relationship? How do you kind of tag team to make sure that a patient is getting their care addressed?
From my perspective, that generally looks like trying conservative things first, as far as therapy, medicines. If those things fail before surgery, I will generally recommend at least one injection, and that's when I would refer to Melissa and Dr. Ogan. Also, sometimes after a surgery, patients can have new pain that pops up, other issues that pop up. So sometimes even postoperative patients, we will send back to pain management.
And then I work with an anesthesiologist that specializes in pain management. So we don't do any type of surgery. Everything that we do is typically for patients that maybe are trying to put off surgery, maybe their other health conditions don't make them a good, safe surgical candidate. Sometimes even surgeons will send them to us to try to isolate which nerves are the problem specifically. And so we may do an injection to see how they respond, and that can kind of help to narrow down what surgical procedures might help them best. So that's kind of how we work back and forth together. The other thing I'll mention is sometimes patients will have surgery in one area and then they will have further degeneration, in a different area of the spine. So that's what we go back and forth with.
And is there elements of maybe some sort of, you said stretching, like physical therapy or things of that nature to kind of add into these injections or in connection with?
Definitely. So the big thing with spine, as far as the low back goes, is core health, core strength or core health. So I recommend to patients, whether they're on the route to needing surgery or not, whether they need an injection or not, always therapy is going to benefit in most cases. Strengthening those core muscles, getting active, focusing on stretching, and therapy, they offer things like modalities. So the Feel Good, the TENS unit, things like that, massage, yes.
Yep. Muscle stimulation
Yes.
techniques. So expanding on what Kayla said, a key component of what we see a lot of times is what we call myofascial pain. So muscle related pain or inflammation. So, we could do injections that may help some of the nerve symptoms, and we're going to talk about, I think, some of the other procedures we offer, but having those muscle treatments along with that really is a big benefit, especially with specific disorders depending on the location of their symptoms.
And I'm sorry if this is a dumb question, but what is the difference between going to like the Benuti clinic versus going to like a chiropractor?
So chiropractors and acupuncture, those types of things are what we call adjacent therapies. So
Okay.
you can do them in addition to the treatments that we offer. Some insurances cover, some don't, but those are always adjacent treatment options. So things you can do in conjunction with the treatments that we're offering. And in most cases, that's fine to do. Obviously, if somebody has a fracture in the back, you wouldn't want to do any adjustments to the spine. So there are certain cases where that would not be recommended, but majority of the time, it's definitely something that can be done.
Insurance also, a lot of times will require physical therapy before we can move on to the next steps. So it varies a little bit, but in general, conservative management is typically something they want and from an insurance standpoint, they want a patient to start with anyway. So Kayla and I try to make sure that we've maximized all those things for the patients and covered all of our bases there.
Sure thing. So let's dive into some of those pain procedure options. Referencing my notes, we've got epidural steroid injection. So you said injection, but what is it? How does it work?
Sure.
Fill me in.
So with an epidural steroid injection, the anesthesiologist uses x-ray guidance. It's called fluoroscopy, and they actually go into the epidural space, most frequently in the lumbar spine. It's on a side approach, so it's right in the same space where these nerves come out. The injection isn't into the nerve, it is actually around the nerve, and they inject a steroid into that space. The steroid doesn't change a structural problem, so that's where Kayla comes in, but it can reduce the inflammation of the nerve that is giving the patient their symptoms. So when we talked about where the symptoms are in the lower extremities, or if it were up in the neck and the upper extremities, that tells us a lot about which nerves are inflamed. And that helps us to decide where specifically that epidural will go. So it is a much more specific procedure than like a labor epidural, because we're using that x-ray guidance and targeting specific nerves.
But with the labor epidural, you want it to cover a wide area. So with that, is that instant pain relief? Does it take a while? How does that work?
It can take up to 2 weeks for that steroid to take effect. When we do that, there is also a small amount of local anesthetic that is designed to kind of reduce some of that nerve irritation in the meantime. It does vary a lot from patient to patient. It can last a varied amount of time too. You know, we have patients that get this done every 4 months. You can do it 3 times a year. We have patients that get one and then we don't see them back for several years. A lot of that has to do with the underlying problem. You know, what led them to pain management. If they have more chronic problems where the discs are, you know, in really bad shape, that nerve's more likely to become re-inflamed more frequently.
But like you were saying, losing weight, strengthening that core, if you're able to relieve some of the pain, then that might allow a patient to actually be able to start working out or whatever it is they need to do.
Yes.
Giving them a little more freedom back, because I'm sure,
For sure.
they appreciate that. Moving on to another type of treatment, we've got radio frequency ablation.
And that's one of our other most common procedures. So with radiofrequency ablation, we're targeting the facet joints that Kayla mentioned earlier. So where the vertebrae actually stack on top of each other, you have moving joints just like anywhere else in the body. Those joints are fluid filled. As we age, they get arthritic just like any other joint in the body. There's tiny branches of nerves in these joints, and they're only responsible for sending pain signals to the brain, meaning that they don't control this feeling in your arms or legs or the movement in your arms or legs. So we can actually go in and destruct those nerves temporarily. So there's 2 different ways to do radiofrequency ablation. You can use heat, or you can actually use a cooled version, and we do both.
Are there pros and cons to heat or cooled?
That's something we're kind of investigating right now to see which one carries more longevity. So not overly. The cooled takes a little bit longer. It's thought to have maybe a little bit larger area of destruction. So that's something that Dr. Ogan's working closely on, trying to reach the greatest benefit. Either way, it usually takes at least 6 months for those nerves to grow back. So it's not a permanent fix, but it is a longer term solution than the epidurals or the steroid, the duration of the steroid.
And I don't know, just a testament to how amazing the human body is. Like, it would stink for the nerves to grow back and the pain to return, but to regenerate in 6 months, like, that seems, I don't know, quick to me, but human body's amazing.
One other thing I'll mention, one of the main differences between an epidural steroid injection and radiofrequency ablation is that the epidural is really good for pain that is radicular or is going down the extremities, whereas the radiofrequency ablation is good for the axial pain that is localized to the spine. So it kind of treats 2 different things.
And so I don't mispronounce it. Please help. Sacroiliac
joint.
Doggone it. Pain. Where does it most often impact?
You can go ahead.
Okay.
But you can fight over it. It's fine.
So the sacroiliac joint, actually, this model doesn't have it, but it's where the pelvis joins the bottom of the spine. So the back of your pelvis joins the sacrum, and it forms a sacroiliac joint. That joint, especially in women, but it can be anybody, can be really prone to inflammation. The nerves run very closely behind that sacroiliac joint as well. So when that joint gets inflamed, arthritic, or even out of alignment, which we see fairly frequently, then you can have some of the nerve irritation as well. So patients will get pain that's really low in the back or even at the top of the buttock with that. Occasionally it will go slightly down the back of the thighs as well.
Now, are there treatment options for that differ from anything we've talked about, or?
So we do steroid injections into those joints as well. It's the exact same medication. It's just different in the approach that it's not actually in the spine. It's not in the epidural space. And a lot of our patients will have symptoms of both. Arthritis is typically widespread. So they may have an arthritic sacroiliac joint, and they may have some arthritic changes in the lumbar spine as well, and even some nerve involvement up there. So discussing with the patient when their symptoms are the worst really helps us to isolate which place it is. With the sacroiliac joints, a lot of times one key thing I'll see, and Kayla, you may add on to this, but they'll have pain with riding in the car. Like that will be a big thing. Prolonged sitting will really aggravate those joints. Whereas when it's coming from irritation in the lumbar spine, prolonged standing or walking is really limited. So it's a lot of times it's about patient symptoms as much as anything as well.
So as you all are working very closely with patients, but in general terms, obviously not to rat out any of your patients, but can either of you describe a case where you've had the patient come in, what they've gone through, and just kind of seen such a great turnaround using some of these methods to heal them?
I think one of my most successful cases, I had a patient come in that had a disc herniation. They really did not have a desire to have surgery. So we started off with medications, steroids, anti-inflammatories, did some therapy, gave a little bit of relief, but not great. So then I referred for an injection. I think it took 2 injections for the patient to get significant relief, and the pain stayed away for almost 3 years. And then the patient slowly had a return of symptoms. She came back and saw me, and they were very mild, but she simply came in just to get on top of it.
Yeah.
So we definitely talked about the route of, you're far enough out, you could try another injection. It's been 3 years. Or we can just start again with the conservative treatments. And so things like more therapy, a round of steroids orally. So we did those things, and she's still doing better. So surgery is not always the answer. A lot of times people think, oh, I have a disc herniation, I'll need surgery. But a lot of times we can get the pain better with these conservative options.
And what about you?
So it's very similar. We actually have a lot of patients that Dr. Ogan has been doing this for, I don't want to misquote, but over 12 years for sure in this area. And I think it's closer to 15. But we have patients that have been coming to him intermittently for years, and they simply are not surgical candidates. And without these procedures, they would not be able to function. It may be as simple as being able to do things with their family, go on vacation. We have patients that are very deliberate in the timing of their injections because they know that I have farmers that keeps them in the fields who will time it to, harvest. And their quality of life is improved significantly. That being said, we have some patients that this doesn't achieve their pain relief goals, and that's when surgery does have a place. Or if there is what we call motor deficits, or if, where they can no longer use their extremities the way that they're supposed to, then it's time to consider those surgical interventions.
And so if I'm talking with my doctor, is it something that they would suggest that I need to see a specialist, or can I just seek you all out directly? How does that work?
For our office, you don't need a referral. So you could simply call and say, want to see the orthopedic spine specialist there, and they could get you an appointment. We do obviously accept referrals as well, but that's not required.
So for our office, we do require a referral of some sort. It could be your primary care provider. A lot of times orthopedists will refer to us, both spine and other ortho specialties as well. And we do prefer that you have a recent MRI. That really helps to isolate things as well. If you don't, then a lot of times we can still get things in and get that ordered. We do have quite a few chiropractors that refer to us as well.
And just for clarity for the viewers at home, you are in which office and you are in which office?
We're actually both at the Sarah Bush Lincoln Benuti Clinic in Effingham, the new building, yeah.
And are you in different offices, or?
Yes, we're actually on different sides of the second floor, so.
Okay, just want to make sure that they can find you if they need you. In our last couple of minutes here, is there anything else that you would like to leave our viewers with that might be helpful to patients? Words of wisdom, prevent the back pain before they need you.
The best advice I could probably give patients is to focus on the spine health early on. So avoiding things that are modifiable. So smoking, that's something that you can modify, in order to prevent that early arthritis. Trying to stay physically fit, focus on core strength. Those are all things that can help prevent progression, sometimes or worsening of back pain.
Anything else?
No, I agree with everything that Kayla said. And one thing that I think you mentioned earlier too, smoking is it's a big determinant of disc degeneration. So that's when we're looking at the whole picture, all of the things Kayla mentioned, weight reduction, not smoking, staying active. I recommend for patients that may have other joint issues that inhibit their ability to exercise, I always suggest water aerobics or even just walking in a pool as well.
That lower impact is a big deal.
It is.
Stationary bike, elliptical, those are all non-impact options that are great.
Awesome. Well, a lot of great information. Thank you so much for coming on the show today. We appreciate it.
Thank you for having us.
Absolutely, yeah, thanks for having us.
Of course. And we hope you'll join us for our next episode of Being Well. And stay tuned later this season. We've got an episode on smoking cessation. So like these ladies said, put it down.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.